Hello, everybody. Thank you so much for the kind introduction and the opportunity to present our work. So I have no conflict of interest to declare. So ACDFs, as we know, are frequently performed. We see a push towards outpatient surgery settings, and we see that the approach itself, the procedure, has a relatively low complication rate compared to other approaches in our settings. But we know that there's a risk of airway compression, although being low, and we know that reintubation and ICU admissions are associated with reduced outcomes and greater hospital charges. So I guess this is all what we are afraid of, a patient with a massive shift in the airway. You can see that the airway is clearly displaced and compromised in this patient at risk. So the way we assessed this problem was a two-way approach. The first one was we did a literature review. We identified potential risk factors for postoperative airway compression, defined as a surgical source. So all of these causes, medical, like fluid overload or pneumonia, were excluded. And the second approach was we then screened our own patients for a postoperative airway compression and matched these to a randomized control group to come up with a scoring system. So out of all the publications, we identified 18 potential risk factors that went into bivariate regression analysis, out of which 6 age of over 65, tobacco abuse, ASA score over 2, a bleeding disorder, and a prior cervical spine surgery and a duration of the surgery of over 179 minutes were identified. Using our own patients, we had 10 out of 1,466 with a postoperative airway compression. The upper cervical spine was excluded from our further analysis because it was 100% predictive of a postoperative airway complication. So these patients should really be considered at high risk. So these are our 5 items that we came up with. The mean score of those that experienced an airway complication was 56, with non-PAC cases at 7. Using the statistical analysis, we found out that a good cutoff point for high-risk patients is 20. Using an internal validation of the same cohort that we had, we showed that the model has a good discrepancy between those receiving an event, in this case a postoperative airway complication, and no event. What are the limitations of this? So this is clearly a first attempt of the risk prediction model. We have excluded radiological parameters such as ossifications or coronal sagittal imbalances to keep it simple, to have non-spine surgeons apply this as well. The literature is very limited, and we are talking about something that has a low incidence but can be dramatic in courses. And thus, it makes it really hard to come up with a prediction model. So the conclusions is it has a strong performance regarding statistical testings. It is very easy to be applied with 5 general categories, and the upper cervical spine should always be considered a high risk for patients. Thank you so much.